So thank you all very much and welcome to Realizing the Potential of a CDK4/6 inhibitor in breast cancer, an examination of the evidence that is transforming real-world practice. So today's faculty, myself, I'm Professor of Medicine at the University of Pittsburgh at the UPMC Hillman Cancer Center at the University of Pittsburgh School of Medicine. We have with us Angelo DeLeo, the Sandro Pitigliani Department of Medical Oncology, from the Hospital of Prato, AUSL, Toscana Centro in Prato, Italy, and Professor Miguel Martin, Professor of Medicine, Head of the Medical Oncology Service at the Hospital General Universitario Gregorio Marañón at the Universidad Complutense in Madrid, Spain. And so I think we're going to have a really good talk today, and hopefully everybody will learn as much, as we will. So let's first start with CDK4/6 inhibitors in breast cancer, give an introduction, and how can really the latest real-world evidence supplement randomized clinical trial evidence and really what oncology professionals need to know. So clinical trials and real-world evidence studies are complementary, and I think this is really important. I think we are actually experiencing this in the COVID-19 pandemic, believe it or not, where we're really trying to decide in a much larger sense, and we've done this a lot now in breast cancer, how we actually use real-world evidence to complement randomized clinical trials. And so really what are the basics of this? And so this just shows randomized clinical trials that support the regulatory approval of new drugs by the EMA in particular in Europe. And Paloma 2, for example, was a trial of first-line Palbociclib and letrozole in postmenopausal women with estrogen receptor positive, HER2 negative metastatic breast cancer, showing here a clear benefit, a hazard ratio of 0.563 with a progression-free survival of 7.6 months versus 14.5 months with placebo. Paloma 3, for example, is a second-line trial showing Palbociclib and fulvestrant in women who had progressed on a nonsteroidal aromatase inhibitor. You can see here the progression-free survival has a hazard ratio of about 0.5. With a PFS in the control arm of 4.6 months and 11.2 months with Palbociclib and fulvestrant. So how do we complement these data from real world? I think real world data add to the body of evidence and provide information that may aid in clinical practice. A randomized clinical trial really is very controlled. It measures efficacy and safety of an intervention in a specific patient population. It's really designed to demonstrate causality to the best way that we can. To do that, you have to be very specified and protocol defined with uniformly assessed endpoints. You randomize patients to a treatment or competitor, and it really want to control as many variables as you can to try to come to some defined answer about a very specific question. Real-world observational studies are a little bit different. They really measure effectiveness and safety of an intervention under real-world conditions. They're not really trying to measure causality. You're not making a hypothesis. You're generating a hypothesis from the data. I think it's really important to know the difference between the two. But on the other hand, they really are measuring things in the real world, how we use the drug. They measure patient-reported outcomes such as quality of life and satisfaction. They provide insight, I think, into practice patterns across diverse clinical settings, and generally in patients who may not necessarily fit the clinical trial criteria. And because of this, we really don't randomize patients, and for that reason, there's biases that may be introduced. One example is confounding bias by indication. So for example, you may want to give somebody a drug because they're sicker. And that may mean that in that particular series of patients, they may have a worse outcome. So you have to be able to control for that when you analyze real-world data. Where do the real-world data come from? They come from a variety of sources. They come from electronic health records, they come from claims, billing activities, disease registries, patient-generated data from home use, data gathered from other sources such as mobile devices. And there's really no limit on the inclusion criteria of this. What you tend to do is you tend to try to match people in that, almost as in a clinical trial. It's called propensity score matching. You do the matching afterwards. You don't do it in front. So in other words, these patients are generally everybody, and then you try to kind of figure out in that registry kind of how to study the data. So real-world evidence is clinical evidence regarding the usage and potential benefits of risks of a medical product derived from analysis of real-world data. Again, it can be generalized by different study designs or analyses. It could be randomized trials, large simple trials, pragmatic trials, and more importantly, I think a lot of what we do now with the registries are observational studies. It may be broadly applicable and generalizable to patient populations clinicians see in routine clinical practice, although there are limitations. I think, as we're going to get to here, on the suitability and validity of the data used and the hypotheses and questions asked and statistical analyses used. I think it's really important. Again, these are mostly observational trials or single arm studies. They don't mean they don't have validity. That's really important. I think the best way to look at real-world evidence, at least to me, and I'm curious to see what my colleagues have to say, is more as a complement to randomized trials. It's not like you have to have one as a gold standard, the other as a gold standard. It's both together, which kind of complement a totality of the evidence. So again, a lot of people use real-world evidence to develop guidelines and support tools. I think that it's nice in the US and I think in Europe as well. Real-world evidence is actually being used now for post-marketing safety and to make regulatory decisions. They can actually use this now to add to the packages of products to actually and potentially do label expansion using real-world evidence. And again, observational studies can actually let us think about new ways of using drugs that maybe we didn't think of before. Again, in a hypothesis-generating mode, it really should be complementary. I don't think you should use one versus the other per se, and this is exactly the idea here. So this is palbociclib and endocrine therapy in men who have metastatic hormone receptor-positive breast cancer. All three of us are very experienced clinical trialists, and we knew that you just couldn't get enough patients. It's 1 out of every 3,000 breast cancers, at least in the United States, is male, and then to now have people who have metastatic disease is even smaller. So to try to do a randomized clinical trial is tough. And so they went to this Flatiron database, which we're going to talk about a little bit later. And what they did is actually went to the database, found a response rate to this, presented it to the US FDA, and in April of 2019 got a label expansion. And so this actually is one way of many that I think people can use real-world evidence to supplement the clinical trials data. This is United States data, where in the pre-CDK4/6 era, the patients with metastatic hormone receptor-positive breast cancer in the first line, 40% received chemotherapy, 60% received endocrine therapy. Now, 2 years into was introduced, the CDK4/6 inhibitors were introduced in the United States in early 2015. You can see here on the right panel that looking at an online medical record examination, 52% of patients received a CDK4/6 regimen, 30% endocrine therapy alone, and only 13% received chemotherapy. So this allows us to see the practice patterns as they change in a large real-world sample that actually, as CDK4/6s were introduced, physicians were using them. So Dr. DeLeo has some ideas, some initiatives he's involved in, and he can actually talk for a little bit now.
Thank you very much, Adam. Actually, I totally agree with the points you raised during the discussion about the relevance of real-world data. And I like very much your sentence when you say it's important to complement the data coming from the randomized trials with real-world data. I think it's extremely important to highlight to our colleagues how much we should consider the real-world data as complementary to the clinical trials data. Now, in the last year or so, there is also a growing interest toward the patient-reported outcomes, because it is very clear that the way we report, particularly the tolerability, the side effects profiles of new compounds in clinical trials may not exactly reflect what happens in clinical practice. So, about 1 year ago, there was a group that is working on both sides of the Atlantic. There are some US colleagues as well as European colleagues working together in the attempt to define what do we mean with patient-reported outcomes and what do patient-reported outcomes add to our clinical practice information. There will be probably a paper, most likely presented, published this year or next year, most likely, 2021. This paper will be dealing with the issue of patient-reported outcome as an additional tool to inform the clinician about the level of acceptance of a new drug by the patient. Patient-reported outcomes are indeed based on the recording of the patient feelings, impressions, ideas, perceptions about the safety as well as the general well-being of the patient herself when at home receiving therapy. And I think this is an extremely important information that has to be combined with the information coming from the clinical trial, as well as with the information coming from additional data, such as the real-world data. We have seen that real-world data may come from different sources, like electronic charts, or any type of recorded information on the treatment and the outcome of a given patient. Patient-reported outcomes are more patient-centered. These are informations coming directly from the patient, collected by nurses or by physicians, and then analyzed. I think this is another area that in the near future will be for sure complemented to the real-world data as well as to the clinical trials data in the attempt to have a better understanding in the clinical practice, which may be the impact on the good as well as on the bad side of a new drug.
So that's really good. And, I think that we should, Miguel, do you have anything to add, Dr. Martin, about this and about your feelings about it?
Well, I fully agree with both of you regarding the relevance of real-world data and patient-reported outcome. The only thing I would like to add is that real-world data overcome one of the main defaults of clinical trials. Clinical trials are sometimes criticized because the inclusion and exclusion criteria are very strict in order to get a very good prognosis population. So if we have data on a different population, the real world population, the data is complementary, and this can overcome this problem with clinical trials.
So, we'll get into, and we'll talk a little bit more specifically in a few minutes. But I think it's important, and I think I agree with both of you that, we need to complement it. It's not one, we always talk about one being the gold standard and the other one not being. I think it's kind of both. I think clinical trials do a very important thing. They kind of help prove, hypotheses for us. And I think real world data expands on those hypotheses and suggests new ways to go as not even confirming things. And I think, again, that's, what we want to get across. So now we're going to turn toward key clinical data on CDK4/6 inhibitors in breast cancer. And for this piece, I'm just going to briefly have Dr. Martin talk about CDK4/6 inhibitors for metastatic breast cancer and the indications for 3 EMA-approved agents.
Thank you. The 3 drugs differ in the schedule of administration. 2 of them are given 3 weeks on, 1 week off, while abemaciclib is given continuously. And to tell the truth, the indications are very, very wide in all European countries. There are some differences between countries, but in general, they are approved essentially in combination with aromatase inhibitors in first line in patients with aromatase inhibitor sensitive, hormone receptor positive, HER2 negative disease, and in second line in combination with fulvestrant. There is the opportunity as well of using fulvestrant in first line with the agents if the patient has received aromatase inhibitors before in the adjuvant setting, or they could receive a fulvestrant plus the CDK4 inhibitor in patients refractory to aromatase inhibitors. One of the main differences between the indications of these drugs in Europe and in America is that we don't have the approval for single agents. Palbociclib is approved in US as a single agent and in other countries, but not in European countries. This is a summary of the situation.
Good. Hey, I want to ask you two actually just a brief question, because it's something that's always intrigued me, is that you see the difference in the target IC50 for all of these three agents. They seem different. Are you surprised that the clinical efficacy of the drugs that we're going to get into in a few minutes is pretty much the same? Does that surprise you at all, even though there's such difference in IC50s on these drugs?
This is a very good question. To tell the truth, we should expect some differences. And the reality is that cross-trial examination don't show any apparent difference in efficacy of the three agents, but maybe this could be different in the adjuvant setting.
Right.
There is a different situation in terms of very, very low tumor burden and other things. But in the metastatic setting, my personal bias is that the three of them perform very similarly in spite of the different kinome profile, as you said before.
Right, they are different kinome profiles, and it's really interesting. I mean, so this just shows you kind of the summary of the first-line trials, and I think kind of telling us, what we were kind of just briefly talking about, that regardless of kind of the partner, whether it's letrozole, whether it's a non-steroidal aromatase inhibitor, and the CDK4, whether it's palbociclib, ribociclib, abemaciclib, really we get overall response rates in the 50s, an improvement of probably 15 to 20% in absolute terms over the baseline response rate from single agent aromatase inhibitor. We get progression-free survivals that pretty much have a hazard ratio of about 0.5 to 0.55, a rough doubling of the progression-free survival with reasonable confidence intervals. And really, when we give these drugs with ovarian suppression in the pre or perimenopausal setting in MONALISA 7, we also see roughly the same result. And then finally, with fulvestrant, even in the first-line setting with ribociclib, in patients, say, who were on an aromatase inhibitor and progressed, we basically see the same result. I mean, it's really striking, I think, that regardless of the setting, regardless of the endocrine partner, regardless of the CDK6 partner, we see a rough hazard ratio of about 0.55 across all of the trials and all of the indications. Same thing is seen actually in the second-line trials. These are all with fulvestrant, at least to the top three. The third one is abemaciclib monotherapy after multiple regimens. But at least for the first three of these, the same thing really holds true. If you average those hazard ratios together, you're going to get about 0.55, regardless of whether you give fulvestrant with palbociclib, abemaciclib, or ribociclib. Something people tend to forget when we go through these trials is that the differences in PFS has to do more with the selection of patients. For example, MONALISA 3 was a lot of women who had de novo disease. MONARCH 2 did not have chemotherapy. And PALOMA 3, 30 to 35% of those patients actually had one line of chemotherapy. So the hazard ratios are the same, but the kind of the characteristics of the patients going into the trials is a little bit different. It actually gives us a little bit of kind of comfort that regardless of the patient, the patient population, we're still seeing that same hazard ratio roughly. The really interesting thing is that these drugs really do improve the overall response rate, and I really want to point out the patients with measurable disease. This is PALOMA 2, but this has been replicated with some of the other trials. Really, you now have a 55% overall response rate, a clinical benefit rate of more than 84%, and a duration of this response that lasts almost 2 years. And I think this is something that's very similar to chemotherapy. In fact, probably a little bit better than chemotherapy, and something we've stressed in the United States, and I'm sure you guys stress in Europe, really is to really think of these agents first when someone comes in with hormone receptor-positive breast cancer. So the thing is that, unless you really have visceral crisis, I think that we really try to encourage people to use the CDK4/6 inhibitor with endocrine therapy first. And again, this shows you the duration. This is abemaciclib. Within 3 cycles, 3 months of therapy, you can have a 30% decline in tumor size, and really peaks. It really lasts a long time, almost the cycle's a month. By about a year, you still continue with that response. And we really can't define a subgroup. I mean, we'll ask you guys about this. But there are no subgroups that really do not benefit, at least from, in this case, palbociclib. But are you surprised by the fact we cannot find a subgroup that doesn't benefit from these drugs? Miguel, Angela, are you surprised by this?
Well,
personally not. I'm not surprised. I must also say, just to to be as much complete as possible, that of course all of these trials were underpowered to demonstrate substantial differences between the different subgroups.
Right.
By the way, despite this potential limitation, it's out of question that there is clearly apparently no interaction between the subgroups and treatment activity. And this is certainly extremely reassuring.
Right. No, I agree. I mean, it's interesting. It is reassuring just looking through the same thing. There's really no subgroup that doesn't benefit. Visceral disease, prior chemotherapy, number of sites, performance status, age in particular. There does not seem to be any differences that are apparent. Again, this is just a pooled analysis from the US FDA of the multiple trials that have been done. They were presented at ASCO 2 years ago. And really, whether you're PR negative, whether you have lobular cancer, bone-only metastases, that hazard ratio in all of these, even though the absolute difference is a little bit different, the hazard ratio still is maintained at about 0.5, 0.55, 0.58, regardless. And it's very comforting, I agree, that it doesn't matter, at least in the clinical trials, that we have not seen any difference. Again, the endocrine partner doesn't matter, ribociclib, tamoxifen, or palbociclib fulvestrant, abemaciclib fulvestrant. Really, regardless of the endocrine partner, we still see that same comforting hazard ratio, again, of about 0.5, 0.55 in these trials. So now, Miguel, I'll let you kind of go through these because this is kind of your topic, having been the PI running JICAM and the PEARL trial.
Thank you, Adam. Yes, this is a very interesting idea to see how these agents, CDK4/6 inhibitors, work as compared with oral non-toxic chemotherapy like capecitabine. The Korean Cancer Study Group did this phase 2 trial comparing palbociclib plus exemestane plus an LHRH analog versus capecitabine in premenopausal women with prior tamoxifen but without any prior aromatase inhibitors. About 50% of the patients were treated in first line and the remaining in second line with tamoxifen as first line for metastatic disease. And the main endpoint of the trial is progression-free survival according to the investigators. And here you have the PFS. This is a phase 2, but it is clear that the CDK4/6 palbociclib in combination with exemestane and an LHRH inhibitor performed better than capecitabine, and this reinforced the idea that this drug should be used as the therapy of choice in first line for this population of patients. Well, our group in Spain, together with the SICO group, ran a different trial. This is in patients pretreated with aromatase inhibitors. So mainly in second line, some of them in third line, and we randomized patients to receive either chemotherapy with capecitabine or fulvestrant plus palbociclib. And as you can see, there is no difference. So for me, the reading of that is that first, in patients with low income, capecitabine could be an alternative to palbociclib in second line. But in the remaining countries, I think that this study, together with the young PEARL, speak in favor of using palbociclib in first line rather than in later lines, because I think that the difference in efficacy in first line versus second line, even though the hazard ratio is the same, the absolute difference is much higher, much larger in the first line than in second line. This is for me the reading of these two studies putting together.
Yeah, before we go on, I mean, so, you know, you had a lot of, we didn't show is you had a lot of really elegant work where, you know, one idea was that you had an ESR1 mutation and therefore the exemestane wouldn't be a proper partner. So you actually did this cohort 2 with fulvestrant and showed that it didn't matter, right? You still didn't have a result. You still had the same result. And so your feeling is that it's the fact that it's a second-line therapy and the absolute differences just aren't going to be seen. Is that kind of the general hypothesis here, why there was no difference?
Yeah, you're right. We were unable to confirm Dr. Turner's hypothesis that fulvestrant could reverse ESR1 resistance to endocrine therapy due to ESR1 mutations. But you know, there is a lot of things to know about ESR1 mutations. The only thing in which our study was coincident with Dr. Turner's studies is that having ESR1 mutation confers a poor overall survival to the patient regardless of therapy. This is a very interesting thing that could be useful in the future in order to run trials in second line and beyond as a stratification factor, because having this mutation is associated with a poorest overall survival.
Okay, very good. So again, speaking of overall survival, you know, we have now overall survival data, at least from the second line trials. And the first one of these that announced was PALOMA-3, which really in its stratified hazard ratio for death really was not significant, but when it was unstratified, it was. Again, you know, this is borderline statistical significance. You can see here there was an improvement in absolute terms of about 7 months in overall survival from Palbociclib, but was not significant. And again, what you were able to do here, if you actually define this as previous sensitivity to endocrine therapy, the endocrine sensitive population, which was about 80% of the 500 patients in the entire cohort, there was about a 10-month overall survival benefit and a hazard ratio of a little over 0.7, so it was about a 28 to 30% benefit if you had endocrine sensitivity to begin with. Looking now at the other trials, abemaciclib for all comers actually did have an overall survival benefit as third-line therapy. You can see here about 9 months, 37 months versus 46, and these curves continue to separate. Again, a hazard ratio of about 0.75. MONALEESA-3, again, looking at this slightly differently. With ribociclib, the same thing, a hazard ratio of about 0.7. So about, again, these trials, again, seem to be very consistent. They seem to be about a 30% improvement in relative terms of overall survival, and that's begun to be seen. And, you know, you're getting total overall survivals in excess of about 3.5 to 4 years as second-line therapy. If you add 1 year to that, because usually most people progress in about a year, you get a little more than a year on aromatase inhibitors, you're now talking about 5 years for most of the women now getting a CDK4/6 inhibitor. So, I mean, this is kind of data. What was done actually, and I think presented at ESMO Breast Cancer a few months ago, was actually looking across all the 3 trials, again, trying to normalize, again, and this is all hypothesis generating, but trying to normalize across all 3 studies the type of patients that you see. Remember, all 3 had measurable disease, but PALOMA-3 can have any prior line of endocrine therapy and actually have at least 1 line of chemotherapy, and 30% of the patients in that trial did. But when you kind of normalize, you try to match and adjust the patients, which again is kind of almost a real-world analysis on randomized clinical trials data, what you find is that basically there's no difference between all the trials in terms of overall survival. And before we go on any further, I want to ask my colleagues, what do you think of this? I mean, is this valid to do? Dr. DeLeo, Angelo, do you think this is a valid analysis to do?
Well, actually, as you said, I think this is clearly just a sort of hypothesis generating analysis. We have, first of all, to remember that all of these trials were unfortunately underpowered to detect statistically significant survival differences. Second, as this analysis highlights, we have to remember that the population of patients entering the 3 trials is different. Particularly in the PALOMA-3 trials, we have patients who have been more heavily pretreated than in the two other trials. And this, of course, can implicate some difference in the overall survival results. And so actually, my personal point of view is that I wouldn't give so much relevance to the fact that in Mona Lisa 3 and in Monarch 2, you see statistically significant difference in survival, while you don't see such a statistical significant difference in Paloma 3. I wonder if this is not just a play of chance, mainly related to the heterogeneity in the population of patients entering the free trials, and also because of the prior lines of therapy allowed in the three different trials. So in the metastatic setting, personally, I wouldn't worry so much. I wouldn't say that two of the three drugs give a relevant improvement in survival while the other does not. I have the impression that it's pretty the same with the three drugs.
Dr. Martin, you feel the same way, I assume?
Yes, I fully agree with both of you. These data are interesting, but just hypothesis generating. And the issue with the lack of statistical significance relates to the sample size of the trials. With the same hazard ratio in the Paloma 3 trial, but having double the number of patients, the p-value probably will be significant. So this is a matter of power. These trials are underpowered to show a significant p-value. And on the other hand, as we will discuss later, real-world data will be able to complement our information regarding the survival benefit with Palbociclib. So I don't think we could claim that some of these agents produce an increase overall survival benefit while others don't.
Yeah. No, I agree. And I think that, given that, I think the major differences, at least we see, at least initially, have to do with toxicity. And there are clear differences in toxicity of the agents. I think, for example, looking at this, the QT prolongation seems to be most evident with ribociclib, 3.6% having a QTc prolongation, with 0.6% having it greater than 500 milliseconds. Diarrhea seems to be predominant with abemaciclib, with a 9.5% grade 3 diarrhea. Increased LFTs, liver function tests appear to be a little bit more frequent with ribociclib. Neutropenia seems to be a little bit more. With ribociclib, you have an 8.4% grade 3, a 1.8% grade 4 LFT abnormalities. You have an increased ALT, a grade 3 with abemaciclib of about 5.8%. But I think neutropenia seems to be about the same with palbociclib and ribociclib, and a lot less with abemaciclib. So these are kind of the ways we, I think, as you both know, kind of decide how to use these drugs. And again, I think before we move on, any comments you guys want to make about kind of the utility of this? I think we're all kind of agreeing that it sounds like, and I think this is a general consensus internationally, that these drugs generally work the same way in terms of efficacy, at least in the metastatic setting. We don't know in the adjuvant setting yet. But the major difference to kind of determine how to use them has to do more with toxicity. Do we have any comments on that before we move on? Dr. DeLeo?
Yes, actually, I think it's quite clear that while the activity of these compounds in metastatic setting, at least, is pretty similar, if not overlapping, the safety profile looks different. It's clear that we have more GI problems with abemaciclib and more myelodepression-related issues with palbociclib and ribociclib. This is for clear. It's clearly a substantial difference. And of course, this may in some way also guide our decision-making process. You may have a patient in which you may be less afraid of inducing GI problems, and you may have a patient in which you feel more comfortable with a potential risk of myelodepression than any other side effect, including, of course, GI problems. So this may be also a way to tailor your treatment depending on the patient who is sitting in front of you. Once again, I think that when we talk about safety, it will be extremely important to detect on the clinical practice setting which may be the relevance of these side effects on patients. And again, I guess that here, patient-reported outcomes may help because they may give us a better flavor of the patient feelings about the side effects related to the use of their CDK4/6 inhibitor compound.
All right, so let's move on a little bit. So now we're going to talk about the complementary real-world data, and I believe things like patient-reported outcomes of CDK4/6 inhibitors in breast cancer. So at least in terms of Palbociclib, for which we have the most real-world data because it has been approved and in use for about 5 years, we have over 230,000 patients in a variety of analyses. IRIS, which is a retrospective chart review in the US, Argentina, and Germany of about 1,000 patients. The Flatiron analyses, which are retrospective analyses of electronic health records, 2.2 million cancer patients treated in about 280 U.S. cancer centers by community physicians. POLARIS is a prospective non-interventional study of about 1,500 patients in over 100 U.S. and Canadian sites, both community and academic, with 3 years of follow-up. Importantly, and I think for our purposes here, quality of life in the geriatric patients I think is really important, and I think that it gives us some very interesting data. And then finally, there was an expanded access program in 2014 and early 2015. There was an air time of about probably 9 months in the United States where we could not give the therapy. So I was one of the sites, there's like 4 or 5 sites in the United States where you can get Palbociclib on an expanded access program. It allowed us to gather some data for patients who had been far treated. I mean, the median number of regimens was 4 or 5. So again, these are the real-world studies. It's around the world. They were ongoing studies with various numbers of patients, various numbers of centers. So the IRIS study was a retrospective medical record review in multiple countries. Again, anybody who was hormone receptor positive and had metastatic breast cancer met the eligibility criteria and had to receive Palbociclib per the label. Their data readouts from the United States, Argentina, and Germany. Both of you, I believe, are involved in the consortium, if I'm not mistaken, that's going to present data on the European experience in IRIS. So this just shows you Palbociclib use across patient types in the United States, Argentina, and Germany. The median age is a little bit younger in Germany than the United States and Argentina. The disease sites generally tend to be more visceral in Germany than the United States and Argentina. So the Germans apparently are treating a more aggressive phenotype, at least initially. The performance status of the patients also seems a little bit better, more 0. Interestingly enough, another hypothesis that comes out in the United States, for some reason, we tend to start at a lot lower dose. So a lot of people are starting at 75 milligrams a day as opposed to and a lot more at 100, where in Argentina and Germany, both in the first line and the second line, women tend to start at 125, although the 100 I'm not as convinced about looking at these data. And again, why that is, I don't think we really understand. But maybe physicians feel they want to dose escalate. They're concerned about the neutropenia more in the United States than in Argentina and Germany. But again, these are hypothesis-generating data. We don't really know why, but there clearly looks to be something that needs to be explained. The percentage of patients who had dose adjustments, despite this, were the same. It's very interesting that more people in the United States started at 75, the lowest dose, but the dose adjustment looked to be the same across all the countries, regardless of whether it was used with a aromatase inhibitor or fulvestrant. And the landmark progression-free survivals here look to be a little bit higher, actually, than those in the clinical trials, which is very interesting. In the United States, the 24-month PFS is 64%. In Canada, it looks to be about 80%. Germany, 85%. Argentina at 18 months is 80% with Palbociclib and letrozole. When we look at fulvestrant, we don't have as much data. Really, the only thing is we have the 12-month PFS, which appears to be about 80% in the United States, 95% at 6 months in Canada, 91% in Argentina. And in Germany, we have a little bit more data showing about 72% of the patients are still alive without progression in the second line. But again, these are small numbers, and as we've talked about, hypothesis generating allow us to kind of figure out, well, why is that? We can maybe come up with a hypothesis, go back to the clinical data that we have, and maybe try to answer these hypotheses. Looking at palbociclib and endocrine therapy again, this is the same data, again cut a different way. Overall survival seems to be very high, 90% across all trials at 24 months, at least in the United States, Canada, and Germany. Fulvestrant, the real-world survival, as you can see here, is almost 100% at 18 months in Canada, 85% in Germany. Again, these data are very reassuring that the things that we've seen in the clinical trials, if anything, were actually a little bit less survival than there is now in the real-world databases that we're analyzing.
At the virtual 2020 ESMO Congress, additional data were reported from the IRIS study. A retrospective chart review of postmenopausal women with hormone receptor-positive, HER2-negative metastatic breast cancer receiving palbociclib combinations was conducted in 5 European countries: Italy, UK, Germany, Belgium, and Switzerland. Demographics, clinical characteristics, treatment patterns, and clinical outcomes, including progression-free rate and survival rate, were analyzed. It was found that a high proportion of patients initiated palbociclib at a dose of 125 milligrams per day. Low rates of dose reductions were observed among these patients, demonstrating good tolerability of palbociclib in the European population. The progression-free rate and survival rates were also favorable for the palbociclib combinations, showing high efficacy across Europe.
We want to move to the Flatiron comparative data analysis. Again, this is a retrospective analysis. What Flatiron did in the United States, they offered an electronic medical record to physicians. They offered it actually at a discount, and so the financial discount was the only thing that Flatiron asked is that they allow them to then take your data in a de-identified fashion and upload it to some national data, some big database that they own. And so what was done here is you took women with hormone receptor positive metastatic breast cancer who were initiated on palbociclib and letrozole or letrozole alone between February 2015 and August 2018, and looked at the real-world progression-free survival and actually overall survival we're going to get to in a minute. And what they did to try to balance patient characteristics was fairly intensive propensity score matching to try to balance the patients that they were looking at. Again, trying to get around the idea that you're having confounding by indication, giving the palbociclib or the CDK4/6 inhibitor to the patients who were actually at highest risk of progression. So they tried to match for that. And this just shows you the comparative effectiveness analysis. What's important here, and I think, again, very gratifying, is that these data are very close. The hazard ratio is a little bit different, 0.68, but it's fairly close. It's not totally different. And letrozole gave a 17.1-month progression-free survival. When you added palbociclib, that was increased by about 7 or 8 months to 24 months. And so this is very good, very interesting, presented a year ago almost at ESMO, at least showing us that you really pretty much reproduce the curves from at least the PFS curves from the large first-line PALOMA-2 clinical trial. And when you unadjust it, when you just use all patients, it looks a little bit worse, but still maintains that hazard ratio about 0.59. But when you propensity score match, you still get that 20 versus 12, almost doubling of progression-free survival with a hazard ratio of 0.55. So again, in this large data set, with propensity score matching, and you could see, in this trial, you can actually see rough reproduction of the progression-free survivals that you see from the actual randomized clinical trials. Angie, Michelle, and a lot of us who were doing this took us a little step further and actually looked at overall survival in these patients. And what you can see, especially with propensity score matching, is that you see a real-world progression overall survival of a little over 3 years, which is kind of what we expect in this setting, and it hasn't even been reached yet when you add the CDK4/6 inhibitor. And I think the really important thing for all of us, and this is going to be a real test to see whether this is really a valid kind of way of looking at things, is that we're now going to have the real world, actually the real survivals come out of PALOMA-2 and some of the other trials, and we're going to compare, and we're going to see how close to actually reality this estimate really was. And if it turns out to be close to reality, then I think it's going to give us a lot of comfort that these sort of kind of analyses do make sense as complementary to the clinical trials, the randomized clinical trials that we do. This was presented at ESMO 2019. Some single-arm data analyses, looking at Flatiron, looking at progression in some single-arm studies that were done. So this shows you, again, very similar to that randomized analysis that was done. The real-world progression-free survival in these patients roughly mimics that of the actual clinical trial, but it's maintained, I think, across just about all ethnicities, age groups, sites of metastases, number of metastatic sites. But again, you still are seeing some progression-free survivals really across various subtypes in this single-arm analysis that kind of are close to at least moving the same direction as the randomized clinical trials. Then, just to show you, here are the male patients from the Flatiron database. And what you can see here is that in the first-line setting in these men, what you can see is that you get a benefit. And this actually was 9.4 months versus 3 months with these men with metastatic breast cancer. And again, because they had such small numbers of patients, 37, 214. Again, this is, probably a tenth of what actually the number of patients that were in the Flatiron database. But what you can see here is that this kind of data that you could gather from a large database and lead to the approval of a drug. And this just shows you the response rate in men, again, showing the safety data, the response rate. Then there was POLARIS, which is a 1,500 patient study in the United States and Canada. Again, looking at, it has quality of life questionnaires, blood sample collection over a 2-year period, and this is some of the preliminary data. I think what's really important about POLARIS is that they collected geriatric assessments. They did a G8 screening tool, activity of daily living tool, that are very commonly used assessments in geriatrics to determine someone's functional status. And they actually presented a report, just to patient characteristics, are kind of similar, what we'd expect. About half got palbociclib and aromatase inhibitor first line. 15% had it a little bit later lines with fulvestrant. But a very generally kind of what we'd expect. The menopausal status was 76% with 14% premenopausal, mostly non-visceral disease, and the performance status was mostly 0 or 1. The starting dose in POLARIS is kind of what you'd expect, maybe a little bit less than we saw in the IRIS trial in terms of 75 milligrams per day, but still, about 10% of the patients started at a lower dose. About a third of the patients had a dose modification during this. Adverse events are, again, what we would expect in POLARIS, mostly neutropenia. Within the first 6 months, there was neutropenia, but again, it was predominantly grade 1, 2, and 3, very little grade 4 neutropenia across the trial. And, there seemed to be a little bit less neutropenia, leukopenia, anemia, and fatigue than reported in the PALOMA-2 trial, and that just may be investigator bias in the study, just not wanting to report it or just not being found in the chart, where in a randomized trial you have to report these complications. And so really it wasn't reported in this. And I think this, to me, was the most dramatic thing about POLARIS to me, is that really these are women now over 70 years of age receiving palbociclib and endocrine therapy, and their G8 scores and their ADL scores did not change. They roughly remained the same. They were clearly a certain percentage of them were already impaired to begin with, but more of them were not impaired. And I think this is a good real-world item that really gives comfort to people giving these drugs to women over 70. You can actually use these data, I think, clinically if you want, even though it's still observational, hypothesis generating, but it's very difficult to do these sort of things in another clinical trial. And we have data now that's at least complementary to the clinical trials that tells us that functional status was preserved in the elderly receiving palbociclib. And finally, we'll just talk about the expanded access program. And again, as I said before, this is about probably a 5 or 6 month experience that lasted until palbociclib was approved. It was about 238 patients. So we had long-term follow-up. We decided to follow these women and try to gain some information from this expanded access program. And again, these were heavily pretreated patients. 75% had received at least 2 or more prior therapies. And then you can see here, that the progression-free survival rate, of the patients, was going to be a little bit less, mainly because they were more heavily pretreated. As you can see, the women who had had 2 or more prior lines had progressed quite dramatically. The overall survival rate, again, with 2 years, again, a very heavily pretreated populations of patients, was about 35%. Now, these are not people that we would treat normally with these drugs. It turns out they'll now all be treated first line because of the survival benefit. But at least this gave us kind of a little bit of a hint that these drugs do have activity even in a heavily pretreated population. Our group, Joyce O'Shaughnessy, Kevin Kalinsky, and Atidya Bardia in the United States put together an experience of our own where we were giving abemaciclib sequentially after failure of palbociclib. And it's interesting, again, these are non-randomized data, hypothesis generating only. But on the other hand, what we find is that if you give it immediately after palbociclib, you can have a real-world progression-free survival of about 8 months. If it's non-sequential, in which you have a lot of things in between, it's about 4 months. So this suggests you can get some benefit of continued CDK4/6 administration beyond progression, potentially by changing the CDK4/6 inhibitor. I think that the important thing here is that one thing it may teach us is that palbociclib may not have a lot of activity if you give everolimus first. A.J. DeCal, who now is an assistant professor at the University of Rochester, did this with our group and a few other groups, showing that the real-world progression-free survival of these women is only 2.9 months if they receive palbociclib after everolimus, as opposed to PALOMA-3, where no one had a everolimus, it was 9.5 months. Now, again, hypothesis generating, because in larger studies there doesn't seem to be any difference. You get still about a 5-month progression-free survival, regardless of whether you had CDK4/6 before or after everolimus. I think real-world data adds to the body of evidence. I think palbociclib has a large, broadly representative evidence base with multiple real-world studies, and there's a lot of real-world effectiveness outcomes with palbociclib. So let's kind of just talk, I think, to the last section here, and I think, assessing the clinical implications and applying this evidence and practical guidance for patient care. I think here are some questions. I think we've kind of talked about this a little bit, but we can kind of get into this for this last section. Would you use this in clinical practice, specifically the overall survival benefit that we see in the first line? I mean, I'll start with Miguel. What do you think? What do you think of these data?
Well, I think that the data you showed are very reassuring in many respects. First, they confirm that the data we obtain in clinical trials are real. So this is very important because some people criticize clinical trials because of the selection of patients and think that they are not representative of the overall population. And this data you showed doesn't support this idea. On the other hand, I think that the data you presented are very interesting, supporting the idea that real-world data are good enough to be taken into consideration because the performance of the drugs in the real life are very similar to the performance in the clinical trial. So we could trust the real-world data. And as you said before, this is an important source of complementary information that put it together with clinical trial information could give us a much more comprehensive view of all these important drugs.
Dr. DeLeo, Angela, do you have any other comments on these data?
Yeah, actually, I think these data are very helpful, of course, I fully agree. Let me comment briefly on two particular subgroups or particular situations that are the situation of the male patients as well of the elderly, because here the real-world data are clearly reassuring us, telling us that actually there is no reason to consider the CDK4/6 inhibitor treatment as a non-effective option in male patients or in elderly patients. Now, the question may be how much we should trust this data, how much we should move this data into the clinical practice, because we are lacking data from randomized clinical trials in the elderly as well as in the male patients. For the male situation, I think there will never be a randomized trial with an appropriate number of patients. So my personal view is that, taking into account that from a preclinical point of view, there is no rationale for thinking that CDK4/6 inhibitor should not work in male, taking also into account the real-world data, personally, I do not have any concern in considering the CDK4/6 inhibitor plus endocrine therapy as a very reasonable option in male patients with endocrine-sensitive, HER2-negative metastatic breast cancer. For the elderly, I personally would be very happy to see complementary data coming from clinical trials. There are trials ongoing. For instance, here in Italy, our colleague, Dr. Biganzoli, from our own institution, is leading a trial for elderly patients running in all the country, aiming to show the effect of a CDK4/6 inhibitor in combination with endocrine therapy, particularly in the elderly population. I think we may need this data from clinical trials complementing the real-world data on elderly that you have just shown. My impression is that the clinical trial data will be on the same line of the real-world data, suggesting that the combination of endocrine therapy plus CDK4/6 is also in the elderly setting the most active therapy. Perhaps there the question that we have still to raise is, are we entirely sure that the combination of endocrine therapy plus CDK4/6 should always be the frontline therapy for all elderly patients? And there, I think, we may still have some discussion, because we as clinicians, we know quite well that sometimes you can still consider endocrine therapy alone as a very reasonable option in a particular subset of frail elderly patients because of different reasons, including feasibility of the combination, tolerability issues, side effects, as well as symptoms related to metastatic breast cancer, which may sometimes be quite mild, not requiring a combination therapy. So I guess that in the elderly context, the main discussion may be upfront versus starting with endocrine and keeping the CDK4/6 as the second line, at least for some elderly patients, particularly those who have a frail profile.
No, I agree. I mean, I think that this is absolutely true, and I think there are a lot of randomized trials that we're going to come up with, that we're actually are in progress, both in the United States and in Europe, that hopefully will kind of reinforce and build on some of the real-world data observations that have been seen. Are there any other real-world studies that we need to talk about? I know the GICAM group, Miguel, has a trial. Is there anything else that we're going to be seeing in the next couple months or years?
Yes, we have a trial started years ago, and this is called Registem, and it will enroll 1,500 consecutive breast cancer patients consenting to be enrolled and providing plasma and tumor samples as well. This is a prospective study with no selection criteria. All comers are included. And I think it will provide real-world data from Spain. We are almost ready to publish the first finding of the study.
Okay. Angelo, in Italy, are they doing the same thing? You have real-world data analyses ongoing?
There is an ongoing effort nationally on real-world data when any type of CDK4/6 inhibitor is combined with any type of endocrine therapy in the front-line setting. The study is ongoing, is recruiting quite well. Honestly speaking, I would not expect big surprise from what we have just presented. I guess that the data that we have presented are strong enough to clearly suggest our real-world data here are entirely endorsing the results which came a few years ago from the randomized clinical trials. I think that for the future, and not only in the CDK4/6 inhibitor field, it will be very important to still continuing having results from real-world data And as you have already mentioned, and I fully agree, it will be very important that physicians will continue to generate real-world data in a completely independent environment.
I think that real-world data will provide a lot of information as well regarding sequencing of drugs, because the clinical trials had very, very few patients with a particular sequence of drugs, and the real-world data could be very interesting for giving us some directions regarding the efficacy of a particular endocrine therapy before or after the CDK4/6 inhibitors. On the other hand, I would like to mention an additional thing regarding real-world data, and this is that, as you mentioned before in one of the first slides, clinical trials provide evidence, but real-world data provide effectiveness. And when you need to perform a cost-effectiveness analysis, you need to have the effectiveness data, not only the efficacy data. This cost-effectiveness analysis will be more and more relevant, at least in some parts of the world. I'm sure that in Europe they are in the future. So real-world data could be very, very interesting for all we said before, but also for providing information regarding the cost effectiveness of the new agents.
All right. So I think this has been a really great discussion of what we currently know about CDK4/6 inhibitors in breast cancer based on the clinical trials and real-world studies, how we use them in practice, and what questions we need to answer. I think that generally the key takeaways are that the real-world evidence is complementary to the clinical trials, that they add areas and really expand on various areas that aren't covered in the randomized data. It's kind of comforting, at least, that the real-world evidence we've seen, in particular with Palbociclib, does seem to match fairly closely the data that we've seen from the randomized trials. And in fact, we're all waiting to see whether the survival data that we've seen in the first line from the Palbociclib studies, the real-world analyses, does match actually PALOMA-2 when that data is eventually presented, hopefully within the year. I think otherwise, I think this has been a great discussion. And so again, thank you very much for joining us today, and I hope all of you listening have found this discussion informative and useful to your practice.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education.